So I see by the iPhone clock that it's exactly 5 o'clock, so we can call the meeting to order. And first order of business is going to be our roll call, and we may, as people come in, sort of modify that roll call because I think that Dr. Drake is going to come in a little bit later. Dr. O'Brien, I'm glad we've got you in.
Oh, I'm here. Diana's here.
Okay, good.
Yes.
All right, so let's go through the call to order. So Narda, if you'll have the honors for us, we'll do that now.
Yes, sir. This is Narda Capicelli. We're taking roll for the meeting this evening, November 10th. Dr. Drake?
Here.
Dr. Gotcher?
Here.
Dr. Hurt?
Here.
Mayor Jacobs?
Here.
Dr. O'Brien?
Here.
Ms. Roma?
Here.
Dr. Shamia?
Here.
Dr. Sousa?
Here.
And Dr. Buchanan? Dr. B?
I'm here, present.
Okay, thanks. Okay, good.
Very good. So I believe that we've got everybody here, so that we should have established a quorum. Is that true, Narda?
Yes.
Okay.
Lisa Wagner is not present, but yes, we still have a quorum.
Okay, so having a quorum, we can conduct business. And the next order of business is going to be approval of the minutes from the October 28, 2020 meeting, which has been distributed to everybody either in paper form or electronic form. Are there any questions, concerns, changes that we needed to look at on those minutes? If none, I'll accept a motion for approval in a second.
I'll motion to approve. I'll second.
We have a motion and a second. Any further discussion on the minutes of the meeting for approval? If not, we can go ahead and have a roll call vote on this. So Nora, if you'll conduct that roll call for us, please.
Certainly. This is Narda Capicelli. We're taking a roll call for acceptance of the minutes from 10/28/20. Dr. Drake?
Yes.
Dr. Gotcher?
Yes.
Dr. Hurt?
Yes.
Mayor Jacobs?
Yes.
Dr. O'Brien?
Yes.
Ms. Roma?
Yes.
Dr. Shamia?
Yes.
Dr. Sousa?
Yes.
And Dr. Buchanan?
Yes.
That passed 9-0. Thank you.
All right. Thank you. So the next
Actually, the forum would be in there.
The next item of business is to set the agenda. So you should see before you, either in print or electronic form, our agenda for this evening. Are there any additions, corrections, order changes, anything like that that we need to discuss?
Mr. Chairman, I don't see the public forum on here. I'm not sure how it got left off, but obviously, and I can't remember, did we do that before or after we set the agenda? I just don't recall.
I don't know. I don't see it on there, but I'm perfectly willing if we can quickly set the agenda, get our public forum started.
Okay, yeah, if we go and set the agenda.
It's number 4 on the agenda.
Oh, it's not, okay.
It's not on mine.
Oh, it's on mine.
Okay.
Do we want to hold on setting the agenda and start the public forum then?
It appears so.
Yeah, we'll do that. We'll jump back to the agenda. So who do we need to contact about starting the public forum?
We're here. We're ready to go.
All
Hi,
right.
everybody. This is Kelsey Wilson. I'm with Knox County Health Department, and I will help coordinate public forum tonight. So the public forum, we have 3 participants today. We'll go ahead and get started. Just so all the participants know, they are all in the meeting right now. They'll have 3 minutes. And if everyone can please say their name and their address before they get started, and Knox County IT will start the timer, and you'll be able to see your time as you begin to talk. So our first public forum participant is Sherry Garrett.
I'm here.
All right, and please
There
state
it
your
is.
name and your address.
My name is
Okay.
Sherry Garrett. I live at 7900 Sharp Road, Powell, Tennessee, 37849. I'm going to be very brief. I just have a few points. Start off with, we've talked about, or you have talked about, the regional issues with hospitalizations and ventilator and ICU capacities. I did the math today based on today's data release. 8.9% of capacity is currently being taken up with COVID patients. 25% ICU capacity is being taken up with COVID patients, and 14% ventilator capacity is taken up with ICU patients. I understand hospitals at this time of the year. I've been in nursing for 30 years. I'm really very well aware that this time of year, all the way up through the winter months into March, that hospitals are full. I've seen many, many, many years of patients lining up in the hallways in the ER. On the floor I worked on, we were a floor with monitors, heart monitors. There were many times we'd have to call the doctor to transfer a patient off the floor who was very stable, but we'd have to call and get them off the monitor before they could be transferred to a regular floor, so we could take a patient from the ER that needed to be monitored. So this is normal for this time of year, for hospitals to be close to capacity. And very briefly, I'm going to quote some things I heard from Tucker Carlson last night. In a democracy, you cannot ignore honest questions from citizens. You can't dismiss citizens as crazy or immoral for asking. Force does not work in a democracy. That's a dictatorship. In a free society, you have to convince the public of your legitimacy. You have to win them over with reason. Democracy is always a voluntary arrangement. The public and myself have questions that have not been answered. Not one of us that I'm aware of has received one email back from any of you we have emailed, with the exception of Ms. Roma. I did receive a response back from her at one time. For the past 3 weeks until yesterday, your email system was down, so no one could contact any of you unless we went to your personal emails, which we have tried not to do that out of respect for that. But at this point, we have no trust in you. We have no trust in your decisions. And many of the things I have heard over the past few months has not encouraged me to trust you at all, and the thousands of other people that I represent. That's all I have. Thank you.
All right, up next, we have Kevin Hill. Mr. Hill, if you can state your name and your address before you get started, please. You have 3 minutes.
Trying to get my notes up. There we go. Kevin Hill, 509 Cambridge Street, Knoxville, Tennessee. Why won't you do your best to facilitate a real back and forth engagement with the public in a format that allows for real debate, instead of merely tolerating, under the requirement of law, public comments that remain unanswered in a meaningful fashion? And on the rare occasion the public's questions are responded to, the answers don't seem to tell the full story. Case in point, recently, Martha Buchanan stated that PCR testing is the gold standard and more likely to generate a false negative. In regard to this claim, either the experts consulted by the New York Times, who stated PCR tests can have a 90% false positive rate for COVID-19 infections, or Buchanan's claims are in error, but both can't be correct. Buchanan made the claim, you can't falsify the presence of genetic material, and this is true. However, she failed to inform the public that even the test manufacturers concede that genetic material from other forms of coronavirus can trigger a false positive for COVID-19. And even when COVID-19 is present, all the test is detecting is a remnant of the viral genetic material left behind. And so given the current test protocols, it is not clear whether the remnant is the result of a recovered person, a person who has T cells from past coronavirus infections successfully fighting off the COVID-19 infection, or any other variation that can create a temporary presence of viral material in the specimen tested. This problem is underscored in several studies. Oxford researchers surveyed 29 studies and concluded that positive PCR test results from samples with cycle thresholds over 24 shouldn't be taken to indicate the presence of any actual virus. Therefore, the authors stated that a binary yes-no approach to the interpretation of PCR unvalidated against a viral culture will result in false positives. Do our local cases confirm positive PCR tests with a viral culture before declaring someone is actively infected? Furthermore, researchers cited by the CDC have acknowledged that even in cycle thresholds at or below 24, they still frequently found no active virus, meaning that so far as available research goes, positive PCR test results over 24, we're at about 37 to 40, appear to never be reliable regardless of how few amplification cycles are used. But it gets even worse. All the studies cited by the CDC were done on people with symptoms. And so what's worse for the regime of mass testing is that none of these studies were done on asymptomatic patients at all. So we have no reason whatsoever to believe that PCR testing is ever reliable for discovering infections in people who don't show symptoms. Please engage the public with honesty and real debate instead of this wall of silence you give us, like right now.
Mr. Hill, 3 minutes. The next up we have for a public forum is Taylor Alex Zukowski. Mr. Zukowski, if you can please state your name and your address, and you will have 3 minutes.
Thank you. So I also have some visuals that I like to show you also. Good evening. My name is Taylor Zukowski. I reside at 1525 White Avenue, Knoxville, Tennessee 37996. So I'm here today to urge the Knox County Board of Health to intervene in the containment of COVID-19 on the University of Tennessee's campus. Recently, university leadership has suggested that our campus's COVID-19 severity is not as severe as Knox County and other surrounding communities. I disagree with the university in this notion. Currently, UTK and Knox County are above 30 daily new cases per 100,000. According to the Harvard Global Health Institute, this puts both jurisdictions at risk level red, the tipping point for uncontrolled community spread. However, you cannot identify a new case without testing people. That's where UTK is severely lacking behind Knox County. And when it comes to the positivity rates among these tests, the data suggests that UTK's testing is limited and most cases are likely going undetected. The testing figures that I represent in these past two graphics are from the PCR tests administered at the Student Health Center on campus. They do not include the pooled saliva sampling. It is important to make this distinction because pooled saliva testing does not identify individual cases. On top of that, pooled saliva testing only applies to residential students. Residential students only make up about 25% of the student population at UTK, meaning that there is no COVID-19 testing strategy for the other nearly 75% of students. As of November 3rd, the Student Health Center has only identified 399 of the 1,820 total cases reported to our university. Today, we are 2 weeks from the last day of classes. The university's current position is that they are only encouraging COVID-19 testing before students return home to their families for Thanksgiving. This decision is being made despite direct recommendations from both Dr. Deborah Birx and the White House to test all students for COVID-19 before they return home for Thanksgiving. This is because, according to the CDC, the highest risk for COVID-19 transmission is large, in-person gatherings where it's difficult for individuals to remain spaced at least 6 feet apart and attendees travel from outside the local area. That's textbook Thanksgiving. And with all due respect, these pictures represent a significant segment of the students that UTK is encouraging to test for COVID-19. This university is choosing to not adhere to Dr. Deborah Birx and even the White House on this issue. This is why UTK needs intervention on this matter. Leadership at UTK is not properly handling this public health crisis. I urge this board to take action and intervene. Thank you.
All right, and that completes public forum for tonight.
Thanks to our participants this evening. So at this point, we'll go back to item 5, which is setting the agenda for the remainder of the meeting.
Mr. Chairman,
Yeah.
Dr. O'Brien, can I just state something for a second since it
Right.
relates to public forum?
Sure.
Our 3 speakers, I want to thank them for coming on and talking to us. Yes, we have not been having interactive forums. We do answer some individuals back via email. Sometimes it's hard to understand what the question is in some of the requests that we get. I want to thank Ms. Garrett for what she brought up about the current season of the year and how that fills beds. I wasn't clear on what her question was and what she was asking when she made the statement at the end. So what she was asking of us. And for Mr. Hill, I know Mr. Hill is passionate about this, has really put a lot of time and effort into this, and I thank him as a citizen who is doing that. And I just want Mr. Hill to understand that we are trying to do the best we can with the best information we can and keeping our, public health regulations at a minimum. And that the one of asking people to wear masks is truly a minimum. And even if it is something that people don't like for a little while, I'm really just encouraging him and others to work with us on that and to be cognizant of the fact that there are people who are getting this disease. There are people dying in our community, and every death is one death too many. And last, for our last speaker, passionate about UTK, want to thank him for what he's doing. That is something, unfortunately, we do not control as the Board of Health, as it's a state education institution. But we thank him for his passion and for what he's presented to us. That's all I want to say.
Dr. Goetcher, if I could address the email situation.
Sure.
That was Knox County IT had done some security updates, especially it's a contact form that we use on those forms, and it was taken down for maintenance and then didn't go back up as I think the first person a public forum said for a number of days, actually a couple of weeks, and that was on Knox County, and my apologies to the board as well as to the public that that situation wasn't rectified sooner. We just didn't know about it. But that it was not an attempt, to silence the public or that the board wasn't getting the emails. And my apologies if emails did go to your private emails instead of the public email.
Thank you, Mayor. So I have a question for Mr. Sanders regarding a response or dialogue with citizens, independent of this forum. If we as individuals interact in a discussion, is that considered board policy? Is it considered an individual citizen to citizen policy? How is that interpreted with us being Board of Health members?
Well, the board only speaks through its policies, or its collective actions. So if you choose to send an email to a citizen or call that citizen on the phone or talk to that citizen in the grocery store, then you are speaking as Dr. Goetcher or whichever member of the board. And you can, of course, just like any other member of an entity, say something along the lines of, I think this is our position, or I think that this is the way we'll go, or this is why we're doing what we're doing. But the only way the board can actually affirm such a statement is to pass a resolution on it. So you're not technically speaking for the board if you have a conversation like that, but you're fully entitled to. And obviously county commissioners, school board members, that kind of thing do so all the time. You're muted, Dr. Goetcher.
Sorry. Okay. So we are back to item number 5, where we're setting the agenda, and you should have before you, either printed or electronically, our agenda for the rest of the evening. Any comments, additions, deletions, or changes in order of the agenda this evening? And if not, I'll accept a motion for approval of the agenda and a second confirming that.
I move to approve.
Second.
So we have a motion and a second. Further discussion on the agenda? Hearing none, since we're ready to vote. So Narda, if you could run through the roll call for us for setting the agenda, please.
Yes, sir. This is Narda Capichelli. We're setting the agenda. Dr. Drake,
Yes.
Dr. Gocher,
Yes.
Dr. Hurt,
Yes.
Mayor Jacobs,
Yes.
Dr. O'Brien,
Yes.
Ms. Rama,
Yes.
Dr. Shamia,
Yes.
Dr. Sousa,
Yes.
and Dr. Buchanan.
Yes.
Thank you. 9-0. Thank you all.
You have unanimously set the agenda. Thank you. The next item on the agenda is the Knox County Health Department's benchmark presentations by Dr. Buchanan. So Dr. Buchanan, if you will lead us through that, please.
Thank you, Dr. Gocher. So while getting here it is, really quickly. So first I'll just run through the local situation. We had 224 new confirmed cases since yesterday. That's a new high for us in a daily number of new cases. We now have 14,534 confirmed cases since March and 776 probable cases. We have 13,487 of our cases are considered inactive, giving us 1,692 active cases. 504 individuals have been hospitalized at some point in their illness. Currently, there are 78 Knox County residents in the hospital. I believe that's a new high for Knox County as well. And unfortunately, we did have 2 more deaths to report today. So we have a total of 121 deaths for Knox County residents from COVID. So the first benchmark, sustained reduction or stability in new cases for 14 days. Over the 14-day period, we experienced 7 red flags, 3 of these on consecutive days, and those most being in our most recent days. Our average new cases, 156 per day over the past 7 days, and 137 per day over the past 14 days. So we are representing this benchmark as red. Our second benchmark, community-wide and sustained and increased diagnostic testing with consistent or decreased result reporting turnaround time. There were 7 red flags and 1 yellow flag in the last 14 days. On 2 occasions, these flags occurred in 3 consecutive days. Lab turnaround time, there have been 8 red flags and 1 yellow flag during this time period. All of these occurred on consecutive days. And this benchmark is also being represented as red. Our third benchmark, sustained or increased public health capability. While our current EPI's team continues to initiate investigations in our desired time frame of less than 24 hours, we continue to represent this benchmark as green. However, it's just important to note with the increasing volume of cases and contacts, it's becoming increasingly difficult for us to meet this benchmark. We have added staff, and we are also looking at other options to allow for more people to help with case investigations and contact tracing. Our fourth benchmark, healthcare system capabilities remain within current and forecasted surge capacity. During the past 14 days, there were 3 red flags, 1 yellow flag detected for the number of inpatients with COVID. However, they were not on consecutive days. In this time frame, there were also 4 consecutive days with red flags for COVID patients in the ICU and 2 red flags for the number of patients on ventilators. However, after speaking with our hospital partners, they recommended that we keep this benchmark at stable yellow. And as usual, Dr. Shamil will share more about the hospital data momentarily. For our 5th benchmark, sustained or decreased COVID-19 related death rate for identified positive probable cases. Over the past 2 weeks, we have seen 18 deaths related to COVID-19, 10 of which have occurred in the past 7 days. The information available leads us to represent this benchmark as red also. Our supplemental data section, which is scrolling to now, the first chart shows our cases per 100,000. Our 14-day trend line shows 29 new cases per 100,000, and our 28-day trend line, and our 7-day trend line shows 33 cases per 100,000. The second chart shows the percent positive for COVID. The 7-day average for percent positive COVID is 14.36, which is up from previous reports. So of note that all of these are trending not in a direction that we would hope. We're back to having several red benchmarks and increasing cases, and then once again having our largest new case count in the past 24 hours. So those are all concerning. I think we need to consider this data carefully as a board and what can we do to help slow the spread of COVID in our community. That's all I have, unless somebody has questions.
Any questions for Dr. Buchanan? If not, thank you for your report.
Thank you.
Next on our agenda.
This is, excuse me.
Oh, go ahead.
This is Maria. I do have a question
Okay.
for Dr. Buchanan. When before have we seen 3 red flags like this?
Or which benchmark? I'm sorry.
In other words, out of the 5, I didn't word that very well. Out of the 5, 3 of them being red. And you may not know that off the top of your head, but that certainly, catches my attention. Like, I don't remember seeing this many reds, and I don't know if you all have that data at your fingertips.
I don't have that data at my fingertips. I do recall that we've had red for some benchmarks in the past. Back in when we had so many cases. Last time we had over 200 cases in one day. That may have been a time. We can go back and look at that, but that's a reasonable question, but I can't answer it off the top of my head.
Dr. Hurt.
Someone else on the board may know. Yes.
Yeah.
Dr. Hurt, this is Jack Gocher. I've actually kept a running total of this. The only date I didn't have a running total is 10/14, but my totals go back to 8/12. And most of the time from 8/12 on, I think we had 1 red for deaths on 8/12. Then we went a fair period of time all the way to 9/9 without a red, and that it was just 1 red, and that showed up as new cases. That sustained on 9/16, then on 9/23 and 9/30, we had no reds, and then the last one I've got is 10/28, and there were no reds then. So this is the first time, at least in my little case series here, that we've got 3.
That's what I thought. Thank you.
You're welcome. Any other questions for Dr. Buchanan? If not, again, we appreciate your report, Dr. Buchanan. And the next item on our agenda is the UT Medical Center update and I guess also regional update by Dr. Shamiya. So Dr. Shamiya, if you have your report ready to go.
Yeah, thank you.
You're welcome.
So we'll dive right in, and I'll kind of summarize at the end. It's very consistent with what Dr. Buchanan showed. So next slide, please. So here we see both in the county and the district that the new cases by week is, after that week we broke 1,000 in Knox County, that we're really just staying there at that high level. You see that we've been there for several weeks. If you look back in the past, when we had these types of peaks, we would be there for 1 week only, and then we would come right down. So that's just another way of representing what Dr. Buchanan already showed us. Next slide, please. So this is the age demographics of those cases. And again, it's as if every age decade just has reached this level of consistency. It's not necessarily what we want to see, or it's not what we want to see, but 21 to 30 is pretty steady. And very importantly, from a hospitalization perspective, 51 and older continue to be a significant portion of those new cases diagnosed. So next slide, please. So as we look across the state, we've made the point before that this has very much become a statewide, well, first of all, it's become a regional issue, but even more so, it's a statewide issue. Remember that the scale is different on those based on the population, but the trend is very much the same in what's happened over the last 3 weeks. Everybody's spiked and everybody's staying up. Next slide, please. So this is in addition, this is just showing the positivity rate that Dr. Buchanan already showed. But what it lets you know is that, I mean, we've had this 7-day period, or excuse me, 27-day period where we've been over 10%. And I think the theme here we have to be really cognizant of is that I think throughout the pandemic, there's been this sense that every new normal gets normalized, essentially. We don't want to normalize what we're seeing here, just because we're at this high rate and people are kind of numb to it. We've been at 27 days at greater than a 10% positivity rate there. Next slide, please. So new hospitalizations always make the point that this is a bit of a lag in terms of how these report, but it's really tenaciously steady at this point is what we're seeing. And then that translates into the hospital census. Next slide, please. So, so this is the last 2 weeks, and what you see, and I've got this broken down a little bit more on the next slide, but obviously we saw that peak at 236, and we've really essentially stayed there, whereas our prior peak was 185. And so if you, next slide, please. So what this shows is just that you see it took us 30 days to go from that 185 to back down to 99 over the summer. And we're 20 days into this, and we're not really showing, I mean, thankfully we're not consistently rising. I will tell you that on that capacity call where all the health systems get together, we have seen a kind of a global increase of, and that doesn't mirror this precisely in terms of numbers because the region's slightly different, but we have seen an increase in the last 5 days. But if you just look at this for what it's worth, you see that for these last 20 days, we really haven't dropped. And the issue there is that as we think about what's coming down the pike related to holidays and whatnot, we've always said it seems like we go up a lot faster than we go down. And so what we're setting the stage for is kind of a stair step type of spike and then plateau. But if we spike again, starting here, we'll be that much higher the next time. So we'd really like to see some recovery in these hospital volumes before the next event, but we're not necessarily seeing that. Next slide, please. So these are just those usual projections from our trend line based on today's data versus the last 2 weeks. And as I've said, the only time I think this is really fundamentally helpful is if we see just a trend week over week over week going in either the favorable or unfavorable direction. And so you see that we do have that at least 3 weeks where we're projecting worse than the weeks before. Next slide, please. And so this is literally a repeat of a slide I showed you 2 weeks ago. I just thought it was worth bringing up again, is that when you think about hospital impact of all of this, it's first of all, not space. We could have space issues just in terms of if the long-term care facilities, which have their own set of challenges around COVID, if they can't take some of our discharges, that could have an impact. But we can surge into space. It's staff that are still the primary concern, and we track on a daily basis, just as all the hospitals do, just who's out on a given day, either because they're COVID positive or COVID pending, and at times that can be significant. Also, just remember that just because we reduce an elective service doesn't always help the situation, because if we're doing that, we're hopefully acquiring staff, but not all staff have the same skill set and training to take care of the patients in need. Other concerns are staff contracting COVID or childcare issues related to COVID. Ultimately, if a surge were really developed and continue, caregiver to patient ratio could be impacted. And then ultimately, We certainly hope that as a society, we avoid this. Overall resources could become strained if hospitalizations increase enough. We've still been able to avoid these situations so far, and we feel that is largely because of the hospital system's collaboration with each other and with the health department. But I will say that when you again see what has happened around us, and there've been in the last 2 weeks more kind of announcements of regional hospitals that have had to slow certain things down. It is a reality. I know out east further, at Ballad, they've described a significant nursing shortage that they've advertised, things of that nature. I will say today, the fact of the matter is that the hospital systems are not just focused on the COVID census. We're trying to look at that in the grand scheme of the entire hospital situation. So even with the census having risen somewhat in the last 5 days, we still felt we were yellow and stable, because you have to look at all the patients, not just the COVID patients, to decide if you're able to deliver services. And then final slide, please. So the key data points, it's what I've already mentioned, that in many ways we've established this new normal of inpatients, of new cases, and the age demographics, which all these numbers are the worst we've seen so far, but they very well may be as good as we're going to see in the coming weeks. This high positivity rate does imply that we may not really have an accurate assessment of how much virus transmission is occurring within the community. We do anticipate at least 2 more significant spikes related to holidays coming up. And just looking at the overall situation, we don't know how much worse, but it seems without some sort of change, it's reasonable to expect a worsening through January and possibly even through April. And I know there's been a lot of quite frankly, very positive news about vaccines this week. And it is positive, there's no question about it. But we have to realize that between distribution and vaccination and all that, that's going to take some time to really have an effect on the situation that we have immediately in front of us related to hospitals. And I believe, Dr. Gocher, that concludes my report.
Okay, any questions for Dr. Shamia? Excellent report. Any questions from board members for Dr. Shamia? If not, I thank you. And the next item on our agenda are educational institution presentations. And I think we have Dr. Greg on the call with us from the University of Tennessee. Dr. Greg, do you have a report for us this evening?
Sure, I do. And I think we
good.
have some slides available there that I'd like to go over. Thank you for having us again tonight. We like the opportunity to present our data, and we'd like to just to give a little bit of insight as to what's going on from a COVID standpoint on campus. With our slides this evening, I'd like to first start with our most recent case count data, and then update you on broader testing strategies and some of the results that we've seen so far. Here on our first graph, again, we're reviewing our active case counts. We presently report 82 active COVID cases. Of those, 77 are students and 5 are employees. We have also had 5 new recoveries reported since yesterday. Next slide. On this graph, we report our daily new cases, and we're seeing that since yesterday, we've had 10 new cases reported. Next slide. On this graph, we're reviewing our current active isolations and quarantines. We currently have 390 individuals in isolation or quarantine. 121 of those are on-campus residential students. 217 are students residing off campus, and 52 are employees of the university. Next slide. This table reviews our most recent campus saliva testing efforts. You can see that we've had consistent participation over the last several weeks, hovering around 75% each week. In the 2 weeks since our last update to the board, we've tested 1,920 total samples in pools of 3 to 4. And from that, we've referred 79 students for diagnostic testing. And of those, 19 individuals have tested positive to this point. Of note, in the past 7 weeks of saliva testing on campus, we've collected 6,614 saliva samples from our on-campus residents, referred 265 individuals for follow-up testing, and have identified 63 positive cases from those pools. Next slide. Our final slide, you can see that the Student Health Center has experienced increased testing that has been directly related to the testing of the asymptomatic patients in our positive saliva pools from our weekly saliva screening. And that's it. That's my last slide. You may have seen or heard that we had identified a new cluster over the weekend. It's our first in about a month. This was a small cluster stemming from a get-together among students on October 31st. It included 5 positive cases and 4 close contacts. We moved quickly to conduct contact tracing and greatly appreciate the cooperation of the students that were involved with that. They reported their health situations to us via our online self-isolation form, and were very open in sharing information with our contact tracers. The willingness of the students to do the right thing was critical in allowing us to do our part to limit the spread. Despite the trends we're seeing on campus, we remain diligent, particularly in the face of rising cases in the broader community and across the state and the country. I know that the Chancellor discussed at the last meeting that we are communicating with our students about how to safely return to their families and communities for the Thanksgiving holiday. We are encouraging all students to have COVID-19 testing performed before they leave for the semester, especially if their plans involve being around others who may be more vulnerable to infection. In order for students to get the results back before the break, we're encouraging them to get tested at the Student Health Center sometime between November the 16th and the 20th. However, testing will certainly still be available beyond that time. Students and employees can also get a free take-home COVID-19 test kit through the Student Health Center if preferred. We'll also be continuing our required community saliva testing for on-campus residents through November the 13th. Any on-campus residential students that test positive will continue to have access to university-sponsored isolation housing on into the break time. We will continue to offer COVID-19 testing to any student desiring to be tested, regardless of whether or not they are symptomatic, and certainly those who have symptoms of infection are encouraged to be tested. We'll also be expanding our campus-wide testing strategies leading up to the spring semester to assist in our efforts to limit community spread when students return to campus in late January. Once we finalize those plans, we'll share that information with the board. And finally, remaining mindful of the flu season, we have another flu vaccine event scheduled this week on campus. So with that, I'm happy to answer any questions that you might have, and thank you again for this opportunity.
Dr. Gregg, I have a quick question. What has been the what's been the reaction or the response to the flu vaccines at the campus? Have you had a lot of takers?
I don't have exact numbers in front of me at this time. We can certainly present that information to the board. We typically on the campus don't have a great response to getting flu vaccine, but we are seeing an increased number of those participating this year, and that's probably for 2 reasons. One is we're having more testing efforts available on campus. Rather than just having 1 or 2 events, we've been trying to schedule 1 major event each month. And of course, it's readily available through the Student Health Center pharmacy here on campus without an appointment. And then the other impetus for probably the increase is the fact that it is a mandated immunization for the spring semester. So students that do not have the immunization will have a hold placed on their account, which can limit some of the things that they're able to do in regard to their academics and activities here on campus. And then also, as you're aware, it's been mandated for the employees here at the university as well.
Very good, thank you. Any other questions for Dr. Gregg from the board?
Dr. Gocher, Pat O'Brien. Dr. Gregg, do you have an idea of what capacity Student Health has to perform testing between now and Thanksgiving for the students? Is it just in gross percentages? Are you able to test 10% or 100%? What do you think?
Well, the university has about an estimated collection of around 30,000 students. I'm not certain how many of those currently reside in the Knoxville area because many are doing virtual classes at this time from home. We certainly have not run into an issue with our capacity. We have plenty of availability of testing throughout the day. One of the problems that we run into is that often due to student schedules, we'll tend to get a run of people that want to be tested at the end of the workday, and we just don't have the ability to maintain staff into the late hours of the evening for students to be tested. We have expanded our hours up until 7 p.m. on weekdays, and we also have included weekend hours to afford a greater opportunity for testing. And certainly as we move into the latter part of this semester here in the next 2 weeks, we will have a greater availability for access to the testing as well, both through the nasal PCR test that we perform here through the Student Health Center, and then also the availability of the Everlywell COVID-19 home test collection kits.
Thank you for that information.
Excuse me, I have a question, Dr. Greg. I'm Ani Roma. Hi. I was wondering, how do you get the word out about the availability of testing on campus? Do you send an email? How do you communicate your event? You spoke of a flu vaccination event. How do you all push that information out? I haven't been on campus anywhere in quite some time, and I'm sure things have changed since my day.
We certainly make that information available through our website, the Student Health Center's website. But obviously, a lot of people aren't just thumbing through our website to try to figure out what services that we have available. So we also use publications that the university has, Tennessee Today, different divisional and department newsletters that go out on a regular basis. We also push that information out through social media, through Twitter, Facebook accounts, and then we also provide that information via emails in some circumstances. I will say that our student population has done a much better job of accessing and reading their emails this semester than what we've seen in previous semesters. So that's become an effective means of communication as well.
Dr. Greg, I had just a quick question as far as the communication with the families of the students around Thanksgiving. I mean, it takes so much discipline in the household, and just the realization that this person who grew up in your house is, for the period of time that they're home for a while, not a household contact. And honestly, even if they've gotten if they've gotten tested, that tells that they're negative at that precise moment. And so, I mean, I know everybody's heard plenty of this, everybody has the drill, but is there any, because from a public health perspective, that's where I have my biggest concern, is just that it's so hard to think that that person that is your child is coming home is not your household contact at that point.
Well, certainly we have communications with parents through the newsletters that we put out to parents. And then also on our COVID-19 website, parents do a lot of searching and investigation on that website as well. And we have information there pertaining to the importance of adhering to the appropriate health and safety guidance. I think one thing that we try to stress to students, especially anytime students come in to get testing just because they're concerned that they could have been exposed to COVID or that they might have COVID, even though they don't have symptoms. We always try to encourage students to understand that one negative test doesn't mean that you're good to go. It simply tells you that information. The utility from the test is if it comes back positive, then you know you're infected. If it comes back negative, then it tells you at that moment in time you were negative, but that doesn't tell you anything about what it's going to be tomorrow. And so we're encouraging the students that do get tested and where it is negative, that it's still imperative that they continue all health and safety guidance, and we'll get that information to parents if that's not already been put out to them as well.
Thank you, Dr. Greg. For institutional presentations, I know that Ms. Wagner is not available this evening. Did she send a report from Knox County Schools, or are we going to just do that at the next meeting?
She did not. However, all of the information she presents is available on their website.
Okay.
So anybody can go look at that. So that's, they continue to, kind of cruise along with the cases, and they have blips where the cases go up and times when the cases are lower. Right now, I know they have 4 schools that are either partially or fully remote due to some due to illness. Mostly it's due to substitute availability.
That's been
That's out of, we have over
That's been a long-standing
88
red
schools.
flag, red zone, as I understand it.
And to be honest, when we have closed the schools in the past for flu, it has, in my memory, it's been a very long time since we closed school for student illness. It usually is staff and substitute availability.
So any final questions from the board or comments from the board about our educational institution presentations this evening? If not, thanks, Dr. Gregg, and also Dr. Buchanan. Thank you for the input on the schools. So the next item on our agenda is finalization of potential metrics, which we've been working on for some time. And Dr. Buchanan, if you'll lead that discussion for us, please.
Okay, so this is very similar to what we saw last time. The proposed metrics for COVID-19 mitigation, escalation, and recession. So if you go to the next slide, please. So what you'll see here is using the positivity rate at 5% as a recession barrier, where we would take things away, and greater than 10% where we would consider escalating measures. And again, new cases, 5 new cases per 100,000, we consider receding or taking things away. And 10 new cases per 100,000 or more, we would consider escalating. All of these are being looked at over a 28-day period as opposed to a 7-day period or a 14-day period based on incubation period. If we're going to make a change, we want to know that trend is there for longer than just one incubation period. After much discussion with the hospitals, and Dr. Shamia may shed some light more on this, they have recommended that we use a traffic light system to represent recession. They would need to be green, and for escalation, they would need to be red. So if you can go to the next slide, please. So here's the positivity rate, and you'll see it's been a very long time since we've been at 5%. We have been over 10%, as Dr. Shamia noted, for a little while now, not as long as when we look at the next slide. So for a positivity rate, we continue to be above 10%, which at this time, if we adopt this, is above our escalation barrier. Excuse me. Next slide, please. So here you see the new cases, and looking at new cases per 100,000, we currently are at, I just said them and now I can't remember what they are, over 20 new cases per 100,000, and about over 14 days are over. And if you look here, our current 28 days is a little over 20 new cases per 100,000, well above the 10 escalation barrier is where we've been. And I believe, do we have another slide? One more slide. And so I might need some help from Dr. Shamia on this one. So here's what the hospitals have recommended that. So green would be normal hospital operations, yellow, which is where we are now, normal hospital operations with high patient volumes, yellow worsening, normal hospital operations with high patient volumes that are going up as opposed to going down, and then yellow improving or falling, normal hospital operations with high patient volumes that are going down. And then red would be normal hospital operations that may be modified due to exceptionally high patient volumes. So Dr. Shamir, do you want to say any more about that, about how you came to this and what your the hospital system's thoughts are?
Yeah, I'll be happy to. I mean, first of all, based on our discussion from 2 weeks ago, I really do think this captures the essence of what we talked about. One thing we really did feel that we needed just to characterize was to stratify yellow, because we know that we could be considered to be higher than normal. Remember, the hospitals stay very full year round in this community. We don't have a lot of excess capacity, and that's even more so around this time of year. And so I think the stratification of yellow is helpful. I don't necessarily think once you're red, you're red. So I don't know that, and to the hospitals, that very much means this wording is that it's not that we're worried. It means that fundamentally something that would be a normal service delivery or the way the hospital functions, maybe in staffing ratios, maybe things of that nature, has been modified. The final thing I think this captures is that, as I mentioned during my report earlier, this is not just about how many patients have COVID-19 or what percentage of the total patients have COVID-19. This is about stress on the healthcare system in general. Now, the reality is if the hospitals are generally quite full, then there's going to be a very strong correlation between higher COVID-19 patient volumes in the census and stress to the system. But this was intended to be broader than just that. And because we were on a Tuesday, we have that conversation every Wednesday before we adjust it, and that will continue. The policy point I would make would simply be that, I mean, what we're seeing around the country is that it does seem to be the hospital stress piece that seems to be prompting kind of local or regional or whatever action that may be. And I think from a pandemic standpoint, we know that's not ideal, that's late, but that does seem to be the reality of what's happening. And so but you would want that to be what the hospitals really feel like that they can't, where are they right now, and not just a number. So Dr. Buchanan, I think this captures where our head is collectively.
Okay. So at this time, I guess from my perspective, one, we need to decide if we're going to use these metrics or not. And I would recommend that if we do decide to use them, that we use them as a guide, not as an absolute. There's contextual things to consider. So as we approach or get over certain levels, we consider making changes. That we use them in conjunction with our current benchmarks. Those benchmarks, we are useful and tell us about the situation in our community. And I guess then we need to decide how we would use them, because if we look at where we are now, we've been above, at least for new cases, we've been above that 10 per 100,000 over 28 days for quite some time. So I'll entertain any questions. I think these are not Knox County Health Department's benchmarks. These benchmarks were developed by our epi team here and the UT's staff analysis team at the University of Tennessee Medical Center. So these are not our benchmarks. These are recommendations, partly made from recommendations you all have made. So we can change them. We don't have to use them. But I do feel like we've discussed them for quite some time. Maybe it's time for us to make a decision about that, and also really determine how we're going to use them.
This is Maria Hurt. I have a question about that actual graph. If Dr. Buchanan, you or your team could pull that, the very last slide. Yes, I have a question in terms of me understanding the trending yellow. My understanding is if hospitals have high patient volumes that are rising, okay, I get that's a rising yellow. Wouldn't that actually though be closer to red And in other words, the third and the fourth, the trending yellows need to be flipped visually. And this may be a minute point, but just for my understanding of understanding what we're expected to understand, that, a rising high is closer to red, which is what we don't want. And decreasing yellow, patient volumes are falling, so that's closer to green light.
Yep.
Is that my understanding?
Excellent point, Dr. Burt.
Okay, thank you.
I have a question for either Dr. Shamia or Dr. Buchanan. So when we have influenza that begins to really take off in late winter often, how does the impact on the hospital vary from where we are now? Because I guess we need to predict, or we need to prepare for sort of we talked about this sort of double whammy that we may get from influenza. How does this compare with what we usually see in flu season? And are we equipped for flu on top of COVID right now?
So I can start with that. I can say that, for example, compared to what was a relatively bad flu season a few years ago, we currently have significantly more COVID-19 patients in our hospital at this time than we would have had of the flu at one time during that year. And so I don't think we have any idea what type of flu season that we're going to have, or whether, for example, mask use will help mitigate that. But to have a significant addition of flu patients on top of what we're seeing right now, that plateau that I showed that may very well spike again in the coming weeks of COVID-19, that will be challenging. There's no, from a capacity standpoint, but maybe we'll be fortunate and we won't see that much hospitalized flu this year.
Were there ever points in the height of the flu season, maybe over the last couple of years, that hospital capacities were taxed to the point that we had to modify our regimens?
Dr. Buchanan, I don't know if you have a recollection. I mean, several years ago, I can't remember exactly the year, 2009, 2010, something, when we had the pandemic flu, there were pockets of stress, but not anything sustained like what we might be potentially experiencing with the numbers we're looking at. Is that fair, Dr. Buchanan, or do you have
fair. That's fair. We've also had at least 2 seasons in my recollection where it wasn't necessarily flu patients, it was just everything during flu season, where we had some ICU bed challenges and some ventilator challenges. But it wasn't just flu, it was a lot of other things happening at the same time, which is kind of what we're talking about now with COVID, 2 respiratory illnesses happening at the same time. So, I think there's beginning to be some information coming out from the Southern Hemisphere's experience of flu season, that what we're doing for COVID does reduce risk. We know washing your hands and cleaning surfaces and staying home if you're sick, we know for sure those reduce flu. There's a good reason to believe that masks might reduce flu as well. So some of the things we're doing might reduce some of our flu cases. We can hope that. But I think your question kind of gets back to, what I thought of when you asked the question was, that's why it's so important that everybody practice the 5 core actions, because we all have to do our part to reduce the cases that then reduce the hospitalizations and deaths. So it's that ripple effect that we're all impacting, and it's for all of us to do. And during the holidays, it's going to be really hard to do. But I think we all need to make that effort, and not just those of us on this call, but our entire community. How do we, we've talked about how we support that. I know help me out, what's the name of the committee? Knoxville Recovers Group is going to be doing some stuff, I think, to help support mask wearing and getting your flu shot, which is really important as well. But I think, we obviously need to talk internally here about how we use these metrics and what they mean, and what, if anything, is there something else that can be done to reduce those numbers in our community. And we've seen the MMWR reports where closing things down does reduce cases. We've also talked about the fact that, here locally, there's not a lot of tolerance for what we have in place now. Is that going to just get worse if we put more things in place? I don't know the answer to that question. So I think that those are the tough discussions we have to have as a board. I think first we need to decide if we're going to adopt these metrics, and if we're going to adopt them as they are, if we need to change them.
Any other discussion on the metrics in general? If not, if there's a, if the mood of the board is such, we could have a motion and a second to adopt these, and then further discussion.
This is Pat O'Brien. I move that we adopt.
In a second.
I'll second.
Second.
So we have a motion and a second for adoption of the metrics. Further discussion.
Dr. Buchanan, I have just one question, and that as to the de-escalation piece. And again, the question, the real fundamental is how are we going to use these? But we went back and forth a few meetings ago about 5 versus 3. 5 was more of a practical decision because 5 per 100,000 or 5%, because of how far that is, and that is a 28-day period. So it would imply that we've really hit a steady state. I guess my only, and I know you also said these are not absolute. These are going to be additional information. They're not just cut and dry. But from the standpoint of repealing a mask ordinance or resolution, because I mean that may be kind of the, once we hit the certain constellation of findings, that's where the discussion will go, unless there's other direction at the level of state. That's the thing that gives me pause at 5 versus 3. And I know 5 seems almost unattainable at this point, even though it's not. If we all do, all work together, we can get there. But if you're at peace with 5, I'm at peace with 5, I think is what I'm saying. But I'm just wanted to ask you that question of 5 versus 3 on case per 100,000 and positivity.
So the original 3% actually came from a Harvard School of Public Health recommendation. And then this board decided to make it 5. So that, I don't know, I don't recall exactly who asked to make it 5, but it originally was presented as 3, and I'm comfortable with 3. It's further away. You did mention the 28-day period. Obviously, that is a steady state, which I think it's probably best to wait till we have a steady state to make some significant changes. But that's a long time with falling cases. I think, right now we have a mask mandate, and do we have one other, the bar closure. We only have those 2 in place. So if we had others in place, I would see that as we got closer to 3 or 5, we would take some of those other ones away. And then the mask mandate would be the last one to go. I have not, it's been a while since I've looked at that, the data from Harvard and the recommendations, and maybe even from the White House. That might be also the White House report recommendation. But, I think at one time I knew the difference between the 5 and 3. It's not significant, 5% versus 3% and 5. So you're also talking about 3 cases per 100,000 or the 5% positivity, or 3% positivity.
I was referring to both, just to try to keep them in line with each other, essentially. So, okay, well, I mean, and honestly, it was, I believe it, that I'm the one that, if I recall, that transitioned it or suggested it be 5, and that was to try to make something, as we didn't know what kind of how many regulations we were going to have, and all these kind of things, and we really hadn't gotten to this conversation of how are we really going to use these. And so that was really to make something more achievable in the broader sense. But I think that, I guess where I'm going with that is if it was really fundamentally about the mask, which we don't know what it will be about, then 3 may have been fine. But the fact that it's 28 days of stability, because here's the other piece of that is that, I mean, we dropped below 5, we're there stable. And let's say a mandate is removed and then we pop back consistently above 5, it would also imply that it would need to be put back in place. And so in that context, I think 5 is probably okay.
Okay. I guess the other, obviously, or not obviously, but, I think we have to think about, if we're going to put these in place, are we going to escalate? I think we have intentions of rescinding when we can, but are we going to consider escalation? And what does the escalation look like? I can tell you what other communities have done. They've closed bars and restaurants. They've limited gathering sizes. And those are the two big things they've done to reduce spread. And if you look at Nashville, I believe they're still pretty restricted, but you also see that their cases are beginning to go up again. So it's not perfect, but it is a way to control it. But I also will go back to what I said 2 weeks ago, where we are as a community, politically and socially. Is our community going to tolerate more measures put in place? I did speak with Mayor Concanon, and the city is considering enforcement of the bar curfew. And so I think we'll see how that, if that impacts behavior, like we talked about before. We're really trying to change human behavior, which is really hard to do. So I'm not sure what the board, I'd love to hear from the board about what your thoughts are, what you consider. When we know closing things down works, we know that. We send people home and make them stay home and don't decrease gathering, decrease group size. That works, but we also know that there's a flip side to that of, people, how fatigued people are with even just the mask mandate, and how much pushback we're getting from just that regulation, the curfew regulation. Not a reason not to take action, but just food for thought.
Pat O'Brien here, and I'm sorry my video, because of where I'm located, it's just not going to work right. I agree, Dr. Buchanan. I think our community is a community that probably won't tolerate many more additions. That what we really need to ask of our community is really strongly work on the 5 core actions, and that we hear you out there, but we also need consistent application of these core actions, especially as we get to Thanksgiving, especially as we get to the December holidays. So we really need that help. But I think moving forward with these additional metrics as just other data points for us to use is reasonable, but they're not hard and fast. And that we have, being honest with everybody out there, we have some time ahead of us before we get rid of a mask mandate. And that's just the honest truth. And that most people seem to be abiding by it and doing quite well. I know my grandchildren are going to school and they don't complain one bit. And there's a lot of people not complaining. And if we can get more people to just make it part of what they're doing, I think we can mitigate this. Our biggest problem is not going to be the restaurants. I don't think it's going to be even potentially the bars. I think it's truly our gatherings at home and among friends. And I think that's where we really need to put our efforts and ask people to double down on trying to be truly, truly careful.
And I just want to take this opportunity to add to that is that there's so much focus on the mask, but boy, the distance is just as important. And that's true inside the home. I mean, I think that they go together. There's not one more than the other, but the masks are clearly the one that gets the attention. But if you're far enough away, then you need that too. And I just think that sometimes folks lose sight of that, whether they be in an automobile or in someone else's office. It's just you need to, anytime you can, you need to have both the mask and the distance. So Dr. Buchanan, the only other, to your original question about escalation, I mean, the thing that I've continually struggled with is here recently is just it's a regional issue. It is a statewide, it's becoming progressively a statewide issue. And as Dr. Gocher mentioned, I think 3 or 4 meetings ago, I mean, this is, we only can act or react to what is in our immediate sphere. But if ultimately things get to a situation where we have to do that and nothing else has been done elsewhere, then we may be put in that position. But it makes more sense to have a broader public health policy, it would seem, as opposed to just a county.
Pat O'Brien. Oh, go ahead.
I was going to say, when we talk about masks, if you look at the data from Vanderbilt and other places, we certainly see that masks do have an impact on cases and hospitalizations. So we do know that they work. They're not 100%. Certainly, they just reduce risk, and that's really, that's what none of us at this table believe we can get rid of COVID right now or even soon. It's going to be with us for a long time and eventually probably be with us forever, because we'll probably end up with a vaccine for COVID on a regular basis. But what our job is and what our community's job is to reduce risk throughout the community. And all those 5 things reduce risk no matter who you are. They reduce your risk, and they reduce risk for those around you. They reduce risk for you. And if everybody we can just get everybody on board on doing those, we really can make a difference. And I also think we'll make a difference in our flu season, which will also help hospitalizations and employers. It's not just the hospitals. As our cases go up, employers lose employees because they're out for quarantine or isolation. Students are out of school because they're out for isolation and quarantine. They can't find substitutes because teachers are sick. And so it snowballs to all the community. The hospitals are that easy thing to see, hospitalizations, because that's really easy and tangible. We don't have a report from all the employers on how many people are out for COVID or other illnesses. But if we throw COVID and flu together, staffing can be a challenge for our local employers.
So this is a question for either Dr. Buchanan or Dr. Shami, or maybe both. We had some very encouraging news within the last 48 hours about phase 3 trials for vaccinations, which showed a high degree of effectiveness. And I think, everybody is sort of buoyed by this, and this is very favorable information. My question would be, because the vaccines are going to be done in serial fashion, and there may be people that wish not to be vaccinated, so it may not be 100%. There's a period of time after vaccination before the effects can be seen. So if you add up all those variables, do you have any idea, if we started our vaccination program within a month or 2, how long it would take for that to have a noticeable effect on things?
And this is totally a guess, but takes a couple of weeks for vaccine to be effective, but with this vaccine, you've got to have 2 doses. Those doses are separated in this particular vaccine that's coming out first, we think, by 28 days, I believe. And again, not everybody's going to take it. Vaccine's going to trickle out. It will not flood the market. So we won't have a big giant supply all at once. The doses that are being made will be distributed across the United States and even some other countries, I believe. So the volume is not going to be very high. So I don't think we see good community penetration with vaccine until spring, summer of next year, if that, maybe not even until fall. We'll see some positive impacts. What we'll see is we'll vaccinate our healthcare workers and our first responders, and Dr. Shamia will see that fewer nurses are out because they're sick, or fewer doctors are out because they're sick. So we'll start seeing those little wins in our community, and as we do that, maybe we do. He starts tracking that, and we can see the impact of vaccination on hospital staffing. and EMS staffing. But full community penetration is quite a ways away. Unless, I mean, I think it's encouraging that, it has such great effectiveness. Lots more data to be presented before they even consider doing the emergency use authorization.
Thank you, Dr. Buchanan. Any encouragement is a wise thing, I think. So thank you. Any other discussion on our metrics? We have a motion on the floor in a second. Is there any other discussions for adoption of those metrics?
I have a quick question for Dr. Buchanan. You had said, I thought what I heard you say is that you didn't know the exact numbers between 3 and 5, but that you thought that the difference was negligible. Is that what I heard you say, Dr. Buchanan?
I don't know that I used negligible, just that it was not large.
So in our discussion or debate on adopting these metrics, do we need to be specific about the 5 versus 3 number?
Well, nobody's offered a friendly amendment for an edit. So if we vote to adopt based on the motions made, we would be adopting them as written.
Right. Okay. Any other questions, comments, debate regarding finalization of these metrics?
I would only say, as the person who proposed, put this up for a vote, that we would use these as informational and not hard, fast, so that the public understands we're not saying we get to 4%. If something else is going on that we need to deal with, we may have a mask mandate, let's say, that goes down below 5. We hope not, but we're not going to be like this turns something off. So I just want that to be stated.
Thank you, Dr. O'Brien. Any other comments or discussions, further debate on our metrics resolution here? Hearing none, is there any, first of all, hearing none, I sense we may be ready to vote. So Narda, if you'll go through the roll call on a vote for adoption of metrics, please.
This is Nori Cappuccilli, and we are taking a vote. Dr. Drake,
Yes.
Dr. Gotcher,
Yes.
Dr. Hurt,
Yes.
Mayor Jacobs,
Yes.
Dr. O'Brien,
Yes.
Ms. Roma,
Yes.
Dr. Shamia,
Yes.
Dr. Sousa,
Yes.
and Dr. Buchanan.
Yes.
Passed unanimously, 9-0. Thank you.
Thank you, Nora. You have adopted our metrics formally at this point. Thanks, everyone. Next up is our review and discussion section on the 2 ordinances that we have in place. One is 2020-1, which is the face covering or mask regulation. And after that, we can discuss the curfew regarding sale and consumption of alcoholic beverages, which is 2020-5. So let's start with 2020-1. Any new information, any information that we need to bring up as we discuss how we've been doing, the acceptance, any positive effects that we've seen as a result of this?
We have fewer complaints. Most of our complaints now are about places where they're not enforcing the mask mandate. And so those have been, we just go out and educate, and that's really been, and I think as I don't know who stated it, somebody stated it, that, the majority of people are wearing masks and complying. It does vary from place to place. And certainly if you leave Knox County, you'll notice there are fewer masks being worn in those other counties that don't have mandates. So it is encouraging mask use. We know mask use decreases cases, and we know mask use is helpful. So I would be in favor of keeping it in place.
Any other discussion? So Dr. Buchanan, just to clarify things, when does 2020-1 automatically expire?
It does not.
Okay.
It stays in place until such time as it's no longer needed. We did agree that we would discuss it at every meeting.
Right. Any other discussions, comments, critiques, anything on 2020-1 from our board? If not, we'll move on to 2020-5. And again, Dr. Buchanan, I'll ask the question on 2020-5. Do we have a time when it's going to expire? Is it within this week that it's going to expire?
It expires, I believe, Thursday at midnight. We set it that way, knowing we were going to have our meeting tonight. So
okay.
Decision. This again, I did speak with Mayor Kincannon, and she is. They are discussing enforcement within the city, and she wanted me to share that with you all and see if you had any thoughts on that or concerns about that. We have approximately 24 establishments that we've had complaints about. They're not changing. Those establishments are not changing much. It's pretty consistent. The same places we receive complaints about. Again, we go out and educate, inform them of the curfew, that's what my staff is doing. And so to date, there have been no citations from KPD or the sheriff's office. We don't have the authority to issue citations for this, so we are not issuing citations. Ours is simply an educational role. And I will say a lot of the places that are violating the curfew are near, not too far from campus. So they're near those areas. And so that's really all I have on that.
Thank you, Dr. Buchanan. Any other points or discussion on 2020-5?
This is Go ahead. Go ahead, Ani.
Are you sure?
Yeah.
Dr. O'Brien had noted that the bigger concern tends to be with those private gatherings. However, I did think it was worth noting that our next meeting is 2 weeks from tomorrow, I believe, which is also the biggest bar night of the year, if not one of the biggest bar nights of the year. I didn't know if anybody had considered that. The night before Thanksgiving tends to be a very big night for the service industry.
This is Dr. O'Brien. As somebody who was in that industry, I can tell you it is the #1 day. And we do need to make sure that the owners of establishments really work to keep doing what the ones that are doing it correctly, keep doing that, and make sure that people are spaced out, that they're wearing their mask when they're not eating or drinking. And, I think a lot of our owners in the community are doing that. We have a few that are not and have stated as such that to keep their business open, they're going to do what they have to do. But we still want them to utilize these other rules. If they're breaking the rule of closing at a certain time, we still want them to strongly encourage following all the core actions.
Excuse me. Any other points of discussion regarding 2020-5?
This is Maria Hurt. Yeah, I was going to say we do read our emails, and one of the recurrent themes that is familiar to me at any rate are the people who are most frustrated with banning alcohols, not just bars, but banning alcohol after 11, are facilities that are following the rules, and they're very, very frustrated with their lateral colleagues, their competition, who are not following the rules. So I think that speaks to how it appears that the majority of businesses that sell alcohol are adherent to the regulation, because they believe, although it's painful and it requires sacrifices, and we understand that, they believe it's for the greater good. And so their beef when they email us is not always with us particularly, but with their competitors. And I would like to say that also sometimes we get feedback from people in the business who are affected by this specific regulation that feel that our decision has unfairly targeted their businesses, that, it's arbitrary and capricious, and it's not. There's ample evidence at this point throughout the nation that it's like radiation. It's time, distance, and shielding. And bars doesn't really offer that. Prolonged alcohol consumption later into the evenings, people lose their inhibitions, and they just don't maintain that distance, the shielding, spending less time away from each other. So there's data to support the reg. And that's why I think it should stand. And I would like to move that we extend it at least until after UT goes home, students go home, and that would be right at the same time as the night before Thanksgiving. So it's about a 2-week extension.
So Dr. Hurt, we have your motion. Is there a second on your motion? And then we can discuss it a little further.
So Dr. Hurt, can you clarify your motion, please?
I move that my understanding is it's going to expire on Thursday, so 2 days. I motion that we extend this regulation for, I have to look at my calendar, a little more than 2 weeks. And we can decide on something, a specific date. Let me look at my calendar here. Because 2 weeks, of course, is Tuesday, which is 2 days before Thanksgiving. So I don't know, maybe we just say I will move to extend it until the end of November.
So we have a motion. Is there a second to Dr. Hurt's motion?
I'll second.
We have a motion and a second. Further discussion.
Yeah, so just looking at our calendar, if we extend it through the end of November, it'll expire before a meeting that we have on the 2nd. That doesn't sound right. The 9th.
Right.
So it would expire in between our meetings. We have a meeting on the 25th of November and then another meeting on December 9th. So it would expire in between those meetings. So
apologies, I think I was still on a 2-week meeting basis in my mind. So I would.
Well, we are meeting every 2 weeks, so that is a 2-week schedule. We'll just have to vote next time on it too. That's fine. Never mind.
Or not.
Yeah,
We can.
Okay. We're going to discuss it no matter what.
So, Dr. Hurt, any change in the motion to reflect the schedule, or are we okay with, we could, if it's, let me give you a hypothetical. If it's going to expire at the end of November and we meet on the 25th of November, we can always proactively jump ahead and just look at it to either rescind it or approve it at that point. And so we wouldn't have to have it like right on the nose of the day that it's going to expire that we would be meeting.
I think we skipped a meeting when we were looking at the calendar. I think that's what happened on our end. We skipped a meeting. It's okay.
Okay. So we'll just have to remember at our meetings, if there's one that's coming up between, that we'll have to be cognizant of that so we can, debate it and act appropriately. So we have a motion and a second for 2020-5 to be extended until November 30 of this year. Any other discussion, comments, or questions?
If I could add something, I think it was Dr. Buchanan that mentioned, it might not have been, but somebody mentioned that, that the students will be going home at Thanksgiving. Typically that bar night that I brought up is because people come from out of town to be with family, and then they go to their hometown bar the night before they're going to be spending time with family. And that could be people the same college age students. It could be anybody who's traveling into Knoxville from from other areas. I just wanted to clarify because I too was in the industry for a very long time.
Any other comments or discussion? And since we may be ready to vote, if there are no other comments or points of discussion or amendments to the resolution, we can go ahead and vote on the resolution, which is to extend 2020-5 to the end of the month. So Narda, if you will go through a roll call with us, please.
Certainly. This is Narda Capicelli. Dr. Drake,
Yes.
Dr. Gotcher,
Yes.
Dr. Hurt,
Yes.
Mayor Jacobs,
No.
Dr. O'Brien,
Yes.
Ms. Roma,
Yes.
Dr. Shamia,
Yes.
Dr. Sousa,
Yes.
and Dr. Buchanan.
Yes.
It passed 8-1. Thank you.
Thank you. You have adopted 2020-5 for the next cycle, I guess you would say. Next on the agenda is item 11, which is length and content of board meetings. And Dr. Buchanan, you have the floor on that, please.
Thank you. Some of our meetings have been rather lengthy, and we have added some, made requests for mental health professionals to come speak to us and others, which we certainly could continue to do. But I guess my question I wanted to bring to the board is, could we simply, for some of the presentations, have them sent out to you prior to the board meeting, let you look at them and come to the board meeting ready to ask questions about those? And, we could make those available to the public so the public could see them too. So that's my question to the board. That just would help shorten the presentation. Actually, the data that both the schools present is actually on their websites. The data I present is on our website. So if we could maybe shorten the length of the meetings, like tonight, we're not debating something we're going to vote on, but we could be. And if we were, this meeting, and that's fine. I'll meet as long as we need to meet to discuss things. But at this point, could we consider that some of the presentations could be sent out ahead of time for the board to review and come with questions if they had any?
Dr. Buchanan, which of the reports do you think we could present in either digital or print fashion, and maybe just discuss the report after everybody's read? Which ones would be amenable to that?
Well, I think my recommendation would be digital, just because we're communicating primarily by email.
Yeah.
And I think the school presentations could be amenable to that, and the schools could be here to let us know if they have concerns or they have questions or anything that you can't see from the data by looking at the report. And honestly, I'd be fine sending ours out. The challenge is when we update our benchmarks. So we'll have to, our challenge is that our benchmarks are updated day of Board of Health, so they would be week-old bread if we send it out the week before. So I'm not sure that's ideal because they do change. But I think, certainly I could shorten that presentation and people could certainly look at the website. We do send those out day of. That's a little bit harder because we update them day of. Dr. Shamia, I know he tries to get the most up-to-date information for us. I don't know if a 48-hour difference would make a difference in the data you present. But I also think there's some nuance to the data Dr. Shamia presents that, is, the school's presentation and my presentation, they are what they are, and the data's there. But Dr. Shamia adds some context and nuance to his presentation that, might not be really part of my presentation or the school's presentation. And I know I'm speaking for the schools, and we certainly would ask them if they're okay with that before we, did that. But I just wanted to run that by the board.
So I guess another point might be if, for example, we had mental health professionals that were going to give us a report, and they gave us a report ahead of time, we would, I guess, hope they would be available at the meeting on Zoom so that we could get more information or ask them questions. So they would still be here, but it might shorten.
I mean, sure. And I guess in thinking about having other people come present, I think we need to know what the ask is. What is it we want to hear from them? But, you know, in order for them to be able to be prepared to present things to us.
Okay.
Dr. Gocher.
Yes.
So just a comment that the one thing I wouldn't want us to lose is that, particularly if this gets worse through November, December, January, is that, I mean, there is a role of just information dissemination of, I know that not that many people watch, but then there may be other things that get picked up. And I mean, this is our voice, this is our vehicle. And Dr. Buchanan, you obviously have your press conferences as another way to disseminate information, but I wouldn't want to dilute that too much. So if there's a balance, and I'm happy to do, from my standpoint, whatever the board feels is best. But there's something, Dr. Buchanan, when you present, there's something about your commentary sometimes that just adds to what we're looking at, I guess.
Having said that, I will say that persons much wiser than me have pointed out that no meeting should last more than about 45 minutes, and you should be wrapping up in an hour. We typically take 2 hours, but I think there's a lot of information that we're sharing. So, you know, I'll go back from that statement a little bit. But in terms of kind of having a cohesive meeting, that there may be something to recommend that. But I don't want that to be in the face of getting information across.
I think, go ahead, Dr.
I want to say, just keep it in mind that our UT students will be going home basically at our next meeting. And so probably for that meeting, as well as a few after that, there won't be much of a UT presentation, would be my guess, or it'd be pretty minimal.
I mean, I'm happy to have the conversation with Knox County Schools and with UT to see what their thoughts are. You know, if I hear from the board that that you want to continue as we are, I'm fine with that. You know, I think just trying to streamline things a little bit, so perhaps we can all get a little time back. And to be honest, you know, we do all the data and the presentations, and then we kind of save our discussions for the end of the meeting. And you know, if it's not tonight because it's only 7 o'clock, but if we're hitting the 8 o'clock, 8:30 hour. I'm just not clicking as well as I do earlier in the day. And so, again, just thinking about our process and you know, so if we did move this direction, and if you're okay with that, I can talk to UT and the schools and see what they think about that. And certainly I've tried to whittle mine down so that I'm really sharing just kind of the salient information that is pertinent to the benchmarks, so that again, I'm not reading too much of a script. And again, all of that's available and covered heavily by the media. But the other thing, the question I had for Mr. Sanders is if we move to that format for the presentations, or the information is already on UT's website and on Knox County Schools website. So would we have to make presentations available to the public if the information's already on their websites?
I think it would be helpful, and it's a best practice too. However, it's probably not strictly required by the law. There's no law that I'm aware of that strictly says that you have to have the physical published pieces of paper or the digital equivalents posted along with your information. What's important for the public to know is when you're meeting and what you're going to be discussing, not necessarily the backup data, for lack of a better word. But having said that, most of our public bodies here in Knox County do follow that practice of providing the backup data. And I think it's a good practice too. And it would be helpful if you could.
Right.
Not sure if that really answers your question, but.
And the backup data becomes part of our minutes that are posted on our website. So, okay.
This is Maria. So here are my thoughts. I agree with Dr. Shamiya that I appreciate your presentation, Dr. Buchanan. You can often offer some nuanced interpretation. One way, I'm just throwing this out there, that I think maybe your presentation could be streamlined just to save you time. And I think for me, at least, it would be very helpful because I'm always writing notes compared to what the results were the last time we met. But perhaps if your presentation was just like side-by-side comparison of the benchmarks since the last time we met, last time this benchmark was yellow and this time it's red, or, ideally it was yellow and now it's green, and just simply go through slides that way rather than all the details that we can always ask if we need more information, but because that's really what we're doing is we're looking at trends. Of course, we're wanting to see that, what the mitigation measures we put in place and ask people to follow, make the trend, move in a favorable direction towards green lights, so to speak. So I totally empathize with all of my colleagues here that, yes, 3.5 hours in without a break and without dinner, not complain. I'm just saying that at some point our capability to really engage and stay on top of things begins to diminish. So I think that might be one way to save you time and yet still keep us informed and offer us an opportunity with the data right in front of us to, ask a question.
Other discussion about length and content? I mean, this could always be done as a trial. I think as long as we have our folks here that are responsible for those reports and could, either answer questions or give us maybe their own summation, that would be more efficient. And at the same time, we would still be able to get valuable input from them. So I think there's a lot to recommend that. And again, not that we're going to be finishing in 45 minutes, but maybe we could consistently finish in 2 hours.
Dr. Gocher, you, Dr. Buchanan, can I just get guidance as to, I'm happy to modify what I'm doing in any way or do it the same, just so I know how to prepare. I don't know how we'll do it getting it sooner, but in terms of how much I tell you, I serve the board, so let me know.
I think based on what Mr. Sanders said, we don't necessarily have to post it when we post our minutes. We need to make it available to the public. So I think, how we're doing it now is probably okay. And I do think that, again, with your presentation, you do bring some nuance and information that we don't have, and certainly the rest of us that can't see. And so I think that piece is really, it tells us more about what's happening in our entire community. Schools are school specific, they're related to our community, but the hospitalizations are not limited to, kids in school or university students. So it's important for us to know what's going on in our schools, and it's important for us to know what's going on at the university. But the level of detail that you bring, I think, is important, Dr. Shamiya. So I don't know that I would change that. I certainly have looked for ways to shorten mine, and I like your suggestion, Dr. Hurd, of telling you guys where we were last time and here's where we are now, and how we got there.
Okay, thank you.
So one person's opinion, I think that Dr. Buchanan and Dr. Shamiya's reports are really the two keystones in our meetings in terms of getting us up to date on what's going on in the county and as well as regionally, because they obviously affect each other. And I think this is also helpful to the public that is listening. So it may be that we have access to that information early on, as does the public, and then maybe have pretty similar to the presentation that you have now, maybe shortening it a little bit. But they're so important to go over, I think.
That's all I have.
Thanks, Dr. Buchanan. Any other discussion on that? That's just a general discussion, but it may be something that we try and see how well it works. And Also, we would appreciate if we have members of the public that are listening and would interact with us in terms of whether they think that's a good idea or whether it works for them as well. If there's no other discussion about that, we're on to other businesses. Is there other business for us to discuss this evening?
Dr. Gocher, Pat O'Brien.
Yes, Dr.
One thing I just want to bring up, I've had some discussions with some county commissioners, some other elected officials, both in and outside Knox County. And one of the things that has been an issue, I know, for our county commission has been their lengthy meetings recently due to public forum and due to the public wanting to express concerns about our actions. Due to this, they are looking to amend their rules of how they operate. And one thing I just want to throw out, maybe as a way to help them and to help the public, would be for us to just think about possibly in our once a month public forum to extend it maybe a few minutes longer, up to maybe 45 minutes. Tonight we didn't need it, but to show some good faith to allow people to speak up. You know, we don't want to keep people from speaking, but we do want to have, we want to get the word from the public, a broad base, and we want to be responsive. And we may also need to think of a way to have some interactive component going forward. I think it is reasonable for people to expect something from us, whether we directly talk to that person who's speaking right then, or instead at the end of a period of public forum, we may comment and kind of answer people, so we're not actually necessarily talking with them. So I just wanted to throw that out. Doesn't have to be any comment now, but I just want to think about that maybe going forward, and maybe in a meeting or two, we might want to consider just adding that to our rules so that we just take a little bit of heat off of our county commissioners. And I do want to encourage other Board of Health members, take a moment and maybe make a phone call, a text to a county commissioner or two and chat with them. I've had two very substantive discussions with county commissioners, and I appreciate their time spent with me. And because of that, I think we have a better understanding of each other. And I think that we do need to have that, given that they have been hit with a lot of time and effort by citizens that have, it's taken a toll on them too. So just for consideration. Thank you.
Thank you, Dr. O'Brien.
Dr. Gocher, just a quick note, and make sure everybody on the board knows. So there was an ordinance change that was withdrawn by the sponsor to make us have a public forum at every meeting to match what county commission does. So just to let you know that was withdrawn by the sponsor. And so just in case you weren't aware of that. And I do, Dr. O'Brien, that would take an amendment to our rules to change that, because I believe the 30 minutes is written into our rules.
That is correct. And part of why I'm saying what I'm saying is due to the actions of county commission.
Dr. O'Brien, would you like to make a motion regarding that, or are we still going to generally discuss it and maybe talk about it next time? What's your pleasure?
I think I just wanted to put it out as informational now and let people think about it. And I'll probably put it on the agenda for discussion at our next meeting, because it would be before we would have public forum. But just to think about adding 15 minutes, which would give an additional 5 people the opportunity to speak.
Okay. So to the board, in your spare time, think about that, and we'll come to the next meeting maybe prepared to discuss it further and maybe have a motion on it. Any other discussion in the category of other business? So in the face of deafening silence, we will accept a motion and second for adjournment, and then plan on meeting next in about 2 weeks.
Move for adjournment.
Thanks, everybody, and we'll plan on seeing you in about 2 weeks.
Second.
There's the second.
And just to clarify, it's our meeting is back to, it's the night before Thanksgiving. It's a week from tomorrow, right?
A week from tomorrow.
Or 2 weeks from tomorrow. 2 weeks from tomorrow. Okay, very good.
Yep.
Thank
Very
you.
good. Well, thanks, everyone. I think this has been a productive meeting this evening and a lot of things to consider. But we will meet in about 2 weeks and go at it again. Thanks very much for everybody's attention and participation.
Thank you.